Welcome from the Breast Cancer Lab to you, our yearly public symposium. Before we get started, I might just ask everyone to pop their phones onto silent, if you could. So it looks like we've got a great audience in the auditorium here today. We're also on Zoom and Facebook Live, so we're streaming out to the world. So welcome to everyone here on site, but also those of you who are Zooming in remotely. My name is Alex Swarbrick. I'm a medical scientist here at the Garvan Institute. I lead a team of breast cancer researchers, and I'll be your host for our session today. So in the spirit of reconciliation, we'd like to acknowledge the traditional owners of the land, wherever you might be in the country, and to recognise the traditional owners' connection to land and sea. Here at the Garvan Institute, we're on the lands of the Gadigal people of the Eora Nation, and we pay our respects to their elders past and present, and to any Aboriginal people here today. So the reason we're gathering today is that in Australia, something like 40 women will be diagnosed with breast cancer today, on average. Now, 30 years ago, when our research efforts were really just starting out, something like a quarter of these women were probably going to die from that disease within 5 years. So a very high number of people. But today, more than 90% of women survive 5 years or more beyond the diagnosis, and the large majority of those women are cured for life. And so this is really a remarkable turnaround in the medical outcomes for patients diagnosed with breast cancer. And a lot of that progress has come through research. Part of that is through improved detection, so screening, ways of detecting breast cancer earlier, but also through the development of new treatments. And we're going to hear a lot about new treatments and a lot of the exciting work that's going on, building on those early gains to take us even closer and closer to where we want to be. But the problem is that despite all those wins, there are still women who have poor outcomes from breast cancer, and something like 9 Australian women would die today from their breast cancer. So we've still got a long way to go before we can offer a cure to everyone. Breast cancer is somewhat unique as well amongst many other common cancers in that it affects women relatively young in their lives. These women are 40, 50, 60 often when they're diagnosed, with many productive years ahead of them at work and with their families and so on. So to address this need, the Garvan Institute of Medical Research has one of the largest breast cancer research groups in the country. And that team really does a lot of research around understanding the basis for breast cancer, why some people develop breast cancer, how it spreads through the body, and how we can best treat it. And really the aim of our meeting today that we hold every day is to open our doors and to have a conversation with you about the latest breakthroughs in research and in medical treatment of the disease. So we're very lucky that we're going to have some fantastic presentations from the patient's perspective, from Australian and international doctors, and from some of the agencies that fund our research. But before we get to those presentations, I'm really delighted today to announce 2 new research grants to be awarded to young cancer researchers to help them initiate innovative new projects in breast cancer research. These awards are generously supported by our event sponsor, Estee Lauder, who've been involved in this event for, I think, 10 years now, which is quite fantastic support. And we're really proud to be part of their Estee Lauder company's breast cancer campaign. So I would like now to invite Emerentia Wilding to the stage. Emerentia is the Managing Director of Estee Lauder Companies ANZ, and we look forward to hearing from Emerentia about the ways in which Estee Lauder supports breast cancer research and to announce the recipients of these 2 generous awards. Please join me in welcoming Emerentia.
Thank you, Alex, for the very warm welcome. I feel truly honoured to be here today to participate in this event and represent all the employees from the Estee Lauder companies. We have been in partnership with the Garvan Institute for 10 years, and this is, I think, the 7th year that we are sponsoring this particular event. And all our employees around all of Australia, in fact, not just Australia, but around the whole world, are incredibly proud of this partnership because, as I'm sure all of you know, the Garvan Institute is at the forefront of research in the field of breast cancer and developing new treatments. So we could not be more proud to be partners, particularly as this is a mission that has been part of our company for over 30 years. 2023 marks the 31st anniversary of the start of the Estee Lauder Company's breast cancer campaign. The story is fairly well known, but if there are any of you who don't know, I'll give a really quick history. The campaign was started by Evelyn H. Lauder, who was the daughter-in-law of our founder, Mrs. Estee Lauder. She, in 1992, had come to the conclusion that she was hearing more and more about friends, family, associates being diagnosed and sadly losing their lives to breast cancer. And yet it was a subject that just wasn't being spoken about. And she embarked on this passionate mission to raise awareness of breast cancer, of the stigmas around women's health, and how we could go about uniting to raise funds for breast cancer, for research, and make a real difference in this world. So the breast cancer campaign, the Estee Lauder Company's breast cancer campaign, that is our largest corporate funding campaign that we do. Between the breast cancer campaign and the Estee Lauder corporate charity fund, we've donated over these 31 years more than $118 million in funding for research, education, and medical facilities. So here in Australia, our employees fundraise throughout the year passionately. Little things all add up. So it's from movie nights to raffles to pink teas in the morning. And all of those funds make it possible for us to be able to be very proud every year to hand or award a grant to, it used to be one researcher. For the past year we did two, and this year I'm happy that it's again two recipients of the award. This award is granted to applicants who are working on a novel or new idea where they really are looking at a different angle, something that hasn't really been explored yet, which is applicable to breast cancer, where they can then provide the preliminary findings that give them the evidence to then apply for funding, for competitive peer-reviewed funding. So this year, as I say, we're very honoured that we have two recipients again. They're both doing incredible work in the field of triple-negative breast cancer, which, again, I'm sure most of the audience are aware, is a very aggressive subtype of breast cancer that has a high mortality rate, even when it is identified quite early. So the first recipient is Andrew Yam. He's a medical oncologist at the Kinghorn Cancer Centre. He's developing a novel immunotherapy against triple-negative breast cancer. And the second recipient is Carly Purcell. She is a PhD student of the Cancer Cell Plasticity Lab. Carly is investigating the metabolic reprogramming of cancer cell plasticity via histone lactation in the triple-negative breast cancer. So on behalf of everyone here at Estee Lauder Companies, I'd like to say congratulations and a very sincere thank you to both Andrew and Carly for the work that they're undertaking. We're looking forward over the year ahead to learn more about what they're doing. Just earlier this week, I had the absolute pleasure of meeting up again with Shabani Gupta, who's, I think, here today, she is, who was a recipient of the award last year. And honestly, it was so heartwarming, and we felt so honoured to hear from her the progress that she made with the grant that she received last year. So I look forward to hearing the same wonderful stories, and I'm really, really hopeful that these grants will lead to great outcomes for these two researchers. So if I could invite Dr. Andrew Yam and Carly Purcell to come up to the stage. It's quite heavy, so thank you. Congratulations. And Carly,
thank you so much.
It is heavy. I think that you just want to take a photo. Thank you. Thank you.
Thank you so much, Amarantia. Thank you for the support of Estee Lauder, and congratulations, Andrew and Carly. That's really very exciting, and they're both such innovative, exciting projects. So we look forward to seeing where they've got to next year. And so we're now very fortunate that a patient of Elgene's has very kindly offered to come and share her own cancer story with us. So Claudia Hamilton Hall is currently receiving treatment for breast cancer and is going to tell us about her experiences and to kind of give us some of her messages as a breast cancer advocate. So Claudia, please come to the stage.
Good afternoon, everybody. It's so nice to see so many of you here today. My story is quite short. A lot of incidental things happened, and it was discovered that I had breast cancer. I hope I'm not as nervous today as I was yesterday. Thank you for the opportunity to share my experience with living with cancer, with a diagnosis of breast cancer. A special thanks to Professor Lim and the team that are running the clinical trial that I'm participating in. The care and follow-up are excellent. After years of diligently having breast checkups, unfortunately, I stopped after the age of 75. About this time, my husband Carl was diagnosed with late-stage multiple myeloma. Our life changed and was put on hold. We focused on Carl's treatment at the Kinghorn Centre. And of course, then COVID came along, and we all know that turned our lives upside down. Sometime in 2021, I received, oddly enough, a letter from my doctor to remind me that I needed a follow-up colonoscopy. So after a couple of weeks, I decided to pop over to my lovely GP and said to her, well, we should make an appointment for that. I'll need a referral. As a matter of fact, I should really have a good, thorough checkup. So I lay on the bed and she started with my breast, and lo and behold, there was a lump on my left breast. So that was the end of any further investigation. She quickly made appointments for me to have a mammogram and a biopsy at the same time. And after that, there were some more other procedures. I was sent to Dr. Lim, who's been looking after me for the past 2 years. The side effects of the medication that Dr. Lim has put me on are quite minimal. Some hair loss, some hot flushes, we all get those eventually anyway, from time to time, and some teary eyes, which I can't figure out why. There are moments of anxiety, of course, but these are really confined to before I go and have my 3-monthly checkup and my blood's taken and my CT scan and my bone scan. After chatting with Dr. Lim, I'm quite relaxed. It was really quite a shock to have received this unexpected diagnosis. I felt numb. My poor sick husband, Carl, was in total shock. He cried more than I did. After a few days, I said to him, well, it is what it is, I can't change it. But I was determined that it was not going to change my attitude to life, and I wouldn't dwell on the disease. I will continue my life as it was before, and I have had a very fortunate and lucky life. I have lots of lovely friends. I engage socially enough for my age, and I have a very lovely, demanding, dark brown Siamese cat. Very loving, and he truly is a wonderful companion to me and was inseparable from my husband. In conclusion, please, girls, keep up your breast cancer checks. Most important, no matter what age you are. If you do have breast cancer, please inquire about getting into a clinical trial. It is a way of helping others. The cancer researchers, oncologists, scientists do an amazing job not only in attending to us as their patients, but what they do behind the scenes, which I discovered yesterday, is mind-boggling. They are truly the unsung heroes in our world. Thank you for listening to me.
Thank you, Claudia. Thank you so much for sharing your story. It's a wonderful story of optimism, so we really appreciate it. I'd like to introduce you now to my colleague, Professor Elgene Lim. He is an absolute star in the breast cancer world. He is at once a laboratory head here at the Garvan Institute. He's the head of breast cancer clinical trials at the Kinghorn Cancer Centre next door, and the head of the cancer research team at the University of New South Wales. So Elgene is a natural connector, collaborator, and I'd like to welcome him to the stage.
Good afternoon, everyone. It's my pleasure to be here today and to see all of you here, particularly the familiar faces, patients of mine. Thank you for coming. Every year we remember Connie Johnson as a part of this proceedings. Connie was a research advocate. She had breast cancer. She and her brother Sam Johnson started a charity called Love Your Sister that many of you would know about. Connie passed away a number of years ago, but we remember Connie and her legacy. And there's nothing better than having a member of Connie's family speak about Connie's legacy. And we're privileged to welcome Hilda Hinton, who's the third member of the trio with Sam and Connie. And she will talk a little bit about Connie's legacy. So thank you very much, Hilda.
Thanks. Hi, my name's Hilda. I'm affectionately known in the family as the other sister. When Connie got diagnosed, the first thing she said was, "What are we going to do?" And Sam and I were sort of trying to offer help with the family, etc. And she said, "No, what are we going to do to stop other young mums dying of this disease?" So she challenged Sam to ride a unicycle around the country and raise $1 million right now. And so he headed off and he made the $1 million after 16,000 kilometres and 364 days, and came back wanting a pat on the back from Connie, who simply said, "What are we going to do next?" She said, 10 million next. The only answer is in science, it's in research. That's our sole focus, and that's what we're going to do. And, you know, the next stage in that was raising $5 million in 5-cent pieces, believe it or not. There's a chance that any 5-cent coin printed in 2015 was in our heart in Canberra. And so basically our partnership with Garvan's been very important to Connie, and as we continue our legacy, obviously very important to us, because the answer is in the research. We're continuing to fund the Connie Johnson Lab. Love Your Sister's nudging $19 million now, and is investing $6 million in the next 5 years with Garvan's MOST program. We're incredibly proud of that, and we reckon Connie would be too. And perhaps we could all ask ourselves, you know, what more can we do? And that's what we do every day in her name. Thank you.
Sorry, AV crew, can you just move the slides forward, please? Wonderful, thank you. So we have the pleasure of welcoming Professor Eric Weiner, who's the director of the Yale Cancer Center, as well as the president of the ASCO board. ASCO is American Society of Clinical Oncology. Eric is the preeminent breast oncologist in the world. His opinion is much sought after by all medical oncologists, and I'm fortunate to have Eric as my mentor when I worked in Boston 14 years ago. And Eric continues to be a big influence, not only on my life, but on the lives of a whole generation of oncologists. I like to think of myself as young, but I'm not that young anymore. This is the second time that Eric's been given this award. He was first given this award 7 years ago, and he would be giving us his perspectives as the president of the American Society of Clinical Oncology about some of the current challenges that are facing breast cancer research today. So I'd like to welcome Eric onto the stage.
I don't think I can talk and hold it at the same time. Whose glasses are these?
It's probably Claudia's.
Okay. Well, Elgene, thank you for those incredibly generous comments. And I'm actually a pretty simple guy. And in fact, perhaps the thing that I'm most proud of in my career is that I've been a breast cancer doctor and I have taken care of, I would say, thousands of women and probably a couple of dozen men over the course of my career. And it's still something that I do and something that I really get a great deal of satisfaction from. And I've really been able to see just a tremendous amount of progress over the last, I won't tell you exactly how many years, but over the last approximately 3 decades. But we still do have challenges, and I'm going to touch on many of those over the course of the next 25 or 30 minutes. So where are we? And I'll confess that there are some medical slides in here and some word slides, and I've tried to keep this at a level that I think is both appropriate for people who may not have medical training, but also recognizing that in many ways you're all experts and you know way more about many aspects of the disease than I'll ever hope to know. And many of you may know much of the medical information as well. So breast cancer clearly remains a major public health challenge. And so in the US alone, almost 300,000 cases of invasive breast cancer in 2022, an additional 51,000 cases of non-invasive breast cancer or ductal carcinoma in situ. There were 43,000 deaths from breast cancer in the US in 2022. That number has remained pretty much about the same for the last 15 or 20 years. However, the US population has increased fairly dramatically. The death rate from breast cancer has continued to decline over these years. And fewer women who are diagnosed with breast cancer lose their lives because of breast cancer. In Australia, I'm told that there are approximately 20,000, 21,000 new cases a year. And hopefully this jives with the numbers that Alex quoted earlier, but around 3,200 deaths each year. That's 3,200 deaths that we would like to totally eliminate. So we often talk about how breast cancer is a heterogeneous, a variable disease, that it's not one disease, that it's a family of diseases. We sometimes talk about how it's different depending on the stage of diagnosis. We talk about how it may differ according to the age of diagnosis. In the US, and I'm going to talk about this more later, but there are major differences in outcome by race, and we will talk about that. And then when we talk about heterogeneity, we often talk about the fact that there are different types of breast cancer. When I was first a breast cancer doctor in the early 90s, a patient would say to me, "What kind of breast cancer do I have?" And I would say, "Well, you have stage 1 breast cancer, you have stage 2 breast cancer." But that was talking about how much cancer there is, because stage is really the size of the tumor and whether there's lymph node involvement and what have you. It's a measure of size or volume. And when we talk about type of disease, what we've learned over the years is that HER2-positive breast cancer is different from triple-negative breast cancer, is different from estrogen receptor-positive breast cancer, and that within each of those types there are other subtypes. And so we think about that as a measure of heterogeneity. But I'm going to propose to you that there's another way of thinking about breast cancer too, and that's thinking about whether breast cancer really has the potential to take somebody's life or not. Because not all breast cancers are created equally, and of course not all women who have breast cancer are the same. And on one side, on the light blue, are what I call non-lethal breast cancers. And believe it or not, and I think many of you would believe this, there are breast cancers that are diagnosed that if a woman were never diagnosed with that breast cancer, she never would know it, and she would die of natural causes 10, 20, 30, 40, 50 years later. And we know that with a great deal of certainty from looks at old studies where people underwent screening. And I won't go into the specifics, but there are a fair number of cancers that simply are not life-threatening breast cancers. Then there's another big group in the middle that aren't all that threatening, but if they're not diagnosed relatively early, and if treatment isn't given, that there's the potential that they could be life-threatening. And then finally, there's a small group, maybe not so very small, but there's a group of cancers that are really highly lethal, that if not diagnosed very, very early, if not treated properly, do have the potential to threaten a woman's life. And when we think about breast cancer, we probably need to think about these very differently. And I've just shown this a different way on this slide. So the red are the highly lethal cancers, and that blue triangle is that when you need to either screen or treat the cancer to avoid lethality. The purple on the line below that are the somewhat slower growing cancers, but the ones that still potentially could be lethal, as indicated by that yellow triangle. And here, there's a lot more flexibility in terms of when you can screen and when you can treat, because they're just not such aggressive cancers. And then down the bottom are these never lethal cancers. And I've taken this is a thought experiment. This is not based on actual data points. But I've taken this out to 25 years, and what you can see is that after 25 years, these cancers are still not lethal. They just either sit there or they go away, and they're just not going to bother someone. And when we do studies, we have to think very carefully about these different types of breast cancer, and more importantly, when we treat patients, we have to think about this as well, because of course, if you treated everyone the same way, you would be over-treating a lot of people, or you might be under-treating some. So as we consider the challenges ahead in breast cancer, we need to distinguish between breast cancers that are not life-threatening and those that are not, and for non-lethal and minimally lethal cancers, we need to really focus on the side effects, the toxicities, every bit as much as we worry about the benefits. Because if we're not careful, we're going to cause a lot more misery than we're going to help than the benefit that we will do. So let's now talk about what I think are the major unresolved challenges. And the ones that are grayed out, I'm going to talk about very briefly at the moment, but we're not going to go into more detail because we just don't have time. So number one, consistent with what I was just talking about, we're going to talk a little bit about avoiding overtreatment. Two, we're going to talk about better approaches for the somewhat more aggressive estrogen receptor positive cancers, a topic that has perplexed many of us for a long time. We're going to talk about eliminating disparities in breast cancer care, because although we would like to think that everyone born on this planet has equal access to care and is going to do equally well if they're diagnosed with breast cancer, that is not the case. It is certainly not the case in the United States. It's more the case in Australia than in many countries, but it's still not fully the case here. And it's an important issue worldwide. And then at the very bottom, and I'll come back to the gray in a second, at the very bottom, I'm going to end talking about enhancing clinician-patient relationships, which one could argue whether that's a major unresolved challenge or not, but I firmly believe that the relationship between the clinician and the patient is one of the key pillars in terms of how a person with a diagnosis of cancer, and specifically breast cancer, it's a variable that affects outcome. In the middle, and I'm just going to mention these very quickly, I think coming up with new treatments for so-called triple-negative breast cancer, where the tumor is not sensitive to hormones and we can't use anti-HER2 therapies, is very important. We need a better understanding of these cancers, so we need to improve our understanding of them and our appreciation of how they differ from one another. And there are multiple new agents that are being developed for these cancers. I actually said about 25 years ago when people, or 20 years ago, when people first started talking about triple-negative breast cancers, we had never used that term. I said that I thought that just identifying them as a group, that beginning to focus on this would ultimately lead to the development of drugs, and that is just what's happened. And of course, many of the pharmaceutical companies have focused a great deal of attention on triple-negative breast cancer because they see it as a huge unmet need for patients and a way to develop new products that will help their company. And that's a good thing for patients. And then we also have a big challenge with cancer in women who have metastatic breast cancer that spreads to the brain, because the brain turns out to be a place that's particularly hard to treat. We've had some improvements in recent years, both improvements in terms of advances in radiation and advances in medical therapies, but we need to do better. So let's first talk about overtreatment. So I would actually argue, and maybe this is more true in the US than elsewhere, but that overtreatment is really rampant. So let's just take these a step at a time. In terms of surgery, there are still a lot of mastectomies that are done that don't need to be done. And in the US, for reasons that none of us really understand, and particularly in big cities like New York, there are a lot of people who undergo bilateral mastectomies when they're diagnosed with a small cancer on one side, and who don't have the BRCA1 or BRCA2 gene. There's no particular reason for them to do that, who make the decision to do this. Now, it's a free world, people can make that choice, but I think oftentimes people are making that choice based more on emotion than on fact, and that's where, of course, the doctor-patient relationship, I think, is really important here. Radiation. Radiation is a very good treatment as a substitute for a mastectomy, but we don't need to give it to everyone. We know that in older women, women over the age of 70, who have estrogen receptor positive breast cancers, that oftentimes we can omit radiation, and recent studies suggest that that may be able to be extended to a younger population. We know that there has been overuse of chemotherapy for estrogen receptor positive breast cancer. We almost certainly give hormonal therapy or endocrine therapy, treatments like tamoxifen and aromatase inhibitors, that are such good drugs and so important, but in some people, we probably don't need to continue them for 10 years or durations similar to that. And in fact, as much as we think of hormonal therapy as a treatment that's much easier to tolerate than chemotherapy, when you start taking a pill every day for 5 years or 10 years, those side effects, can, in some people, mount up over time. Some people tolerate them beautifully. I see somebody nodding in the front row. And believe me, if you tolerate a drug beautifully, then you don't have to worry about this as much. But if you don't, there are people for whom it's really difficult. One of our speakers yesterday was talking about the fact that oftentimes with hormonal therapy, we make a decision at 5 years whether to continue for another 3 to 5 years or whether to stop it. And she said, listen, I don't have to make that decision at all. My patient walks in the room and they make the decision for me. Because at the end of 5 years, they're ready to either get off it, and that's the first thing they want to do, and they want to throw the prescription in the trash, or they say, I don't have any side effects. This is my safety blanket. I want to continue it. And finally, there is overuse of chemotherapy in other situations as well, particularly in the setting of HER2 positive breast cancer. So there is this problem, and in as much benefit as there is associated with screening, we know that screening can also lead to overdiagnosis. And by overdiagnosis, what I mean is finding those non-lethal cancers as a result of screening, the cancers that would never, ever bother anyone. And suddenly someone, because they have a mammogram, goes from being a totally healthy person to being somebody who has cancer, and yet they're someone who might never know they had cancer if it were not for that mammogram. The challenge for us is we still don't know how to separate those cancers from the other cancers. So I don't have a magical solution. But what I do know is that eventually we have to figure that out so that we can get smarter and minimize the treatment for some and maximize it for others. And there's a recent study that suggests that overdiagnosis is particularly a problem in an older patient population. And that in spite of screening in this work that was done, there was no difference in the absolute numbers of cancers that were diagnosed that were of higher stage, or of the number of people who died from breast cancer in an older population. However, be careful before you believe everything that I just said, because we also know that in older women, that the chance of dying from breast cancer, if you're diagnosed of it, is higher than in younger women. So we can't simply assume that all cancers in older women are insignificant, that they're not going to be a problem, because for whatever reasons, if you're an 80-year-old woman, an 85-year-old woman, a 75-year-old woman diagnosed with breast cancer, you're actually at higher risk of dying, not just dying, but dying from that breast cancer than a 40-year-old woman is. So we do have to think through these things very carefully. But it's, as you probably know, in the area of prostate cancer, there's a whole subset of men with prostate cancer, diagnosed with prostate cancer, oftentimes based on screening, who have what is thought to be very low-grade prostate cancer. And you may have heard it said that all men, when they get old enough, eventually will develop prostate cancer. And in the setting of prostate cancer, there is now, for certain men, an approach that is referred to as watchful waiting, where in fact no treatment is given and people monitor the PSA level and do re-examinations, sparing people the side effects of therapy. And we're probably at a point with breast cancer where that's something that's going to begin to carefully be studied in the years ahead. I know it terrifies some of you, but it's that's okay. If it didn't terrify you, you wouldn't be human. But at the same time, we also have to think very, very carefully about all the unnecessary treatment that is sometimes given. And part of the reason it terrifies people is that psychological factors and risk perceptions are complicated, and that it's been shown over and over again in a variety of experiments in social sciences that in fact we as people are risk averse. We don't like risk when there are potential losses. So if there's the potential that somehow not getting that mammogram in an 85-year-old woman is going to cause a problem, we don't want to go there. Even if the data would otherwise tell us perhaps we should. And I'm picking on an 85-year-old woman, but you know, these questions equally apply to younger people as well. And so, again, we have to think very, very carefully about these issues. Now, how can we safely back off on chemotherapy? I was just talking about backing off on diagnosing cancers entirely. This comes on the heels of knowing that there are a number of situations where we can back off. And over the past several years, past 10 to 15 years, we have very deliberately backed off on chemotherapy, largely in women with estrogen receptor positive breast cancer. And we've done that because we had a hypothesis many years ago that in fact chemotherapy for many women with estrogen receptor positive breast cancer who were newly diagnosed just didn't do very much good. That as much good as hormonal therapy, tamoxifen, aromatase inhibitors, others therapies did, the chemotherapy added very little. So this very large clinical trial was conducted with a test called Oncotype DX, which is a 21 gene assay that helps us predict both whether a cancer is more or less likely to recur and whether chemotherapy is effective. And they enrolled 11,000 patients in the trial, and 6,700 of them who had middle range scores on that Oncotype test were actually randomized, randomly assigned to either get hormonal therapy alone or hormonal therapy plus chemotherapy. Maybe the words are there. That was not supposed to come out this way. Anyway, it says you can't ask for more. Maybe I can even, no, I can't, I'm not gonna edit it. But the bottom line is if people had scores of 11 or less, they had a 99% chance of remaining free of a recurrence of cancer, and I call that you can't ask for more. If at 5 years your chance is 99.3% of remaining cancer-free, that's pretty good. I don't think any of us are going to argue with that. So then let's go to the next. These are the people who were randomized. And as it turned out, if a woman her tumor had a score between 11 and 25 on this test, and she received chemotherapy, she got no benefit whatsoever. And you can tell that because look at the graph and you can see the overlapping, supposedly I have a point, no, that pressed the wrong one. Back. Here's there we go. These two lines are totally overlapping, meaning that chemotherapy added nothing. There was one group where chemotherapy might have added a little bit, and that was in women who were between the ages of 40 and 50. But something happens when you give chemotherapy to a woman who is 40 years old. For those of you who were in your 40s and who received chemotherapy, you know what this is, and that is that you go through menopause very frequently when you get chemotherapy at that age. And in fact, the likelihood is that the chemotherapy benefit here was all about going through menopause, not about the specific drugs. There was a second study that looked at this same question in women who had positive lymph nodes. And again, in some of the women, the postmenopausal women, no benefit whatsoever from chemotherapy, shown on the left-hand side. In premenopausal women, there was a benefit. But here again, it is very likely that much of that benefit is arising because you put people into menopause with chemotherapy. And, oh, where's the slide? I must have taken it out. Okay. And what we know is that just putting someone in menopause with a drug that turns off ovarian function does just about as much good. All right, we're going to go past there. So in HER2-positive breast cancer, of course, the big advance initially presented in 2005 was the use of Herceptin to help prevent recurrences. Before that time, women who had HER2-positive breast cancer with lymph node involvement would get chemotherapy. Many of them would have recurrences, and this new drug, Herceptin, which had been used in women with advanced breast cancer, was tested to see if it could prevent recurrences. And the challenge we had was that it worked very well, but the chemotherapy that was given with the Herceptin was a pretty toxic chemotherapy regimen. And so when I was at Dana-Farber, we did this study, which involved using a very simple chemotherapy regimen with Herceptin. And we did this study in 400 women, and lo and behold, 10 years later, what we demonstrated is that if you got chemotherapy that was a short course of chemotherapy with Herceptin and you had a node-negative cancer, then in fact, at 10 years, you had a 96% chance of remaining free of a recurrence of cancer. And again, pretty hard to argue with such good results. And what that has done is it has allowed us to use treatments like Herceptin and now treatments like Herceptin, and sometimes in some women the drug pertuzumab, another antibody, and to back away from chemotherapy. And this is a trend that you're going to continue to hear about, which is that non-specific treatments like chemotherapy, while useful, are going to be given in greater moderation in the years ahead as we develop targeted therapies like Herceptin and pertuzumab and others. So I'm just going to go past some of this, and I'm going to talk about estrogen receptor positive breast cancer that is high grade, not the very slow-growing estrogen receptor positive breast cancers that fall into the non-lethal category, but the ones that potentially can threaten someone's life. And what we know about these cancers is that they have a higher risk of recurrence, that they're more resistant to hormonal therapy, and that there's less benefit from chemotherapy. And you might say, how do we know the difference between these high-grade cancers and low-grade cancers? And the answer is the pathologist can help us, and we have genetic tests that can help us determine this. And so just last week, at the so-called ESMO meeting, which is the European Society of Medical Oncology, this study was presented. So you can consider yourselves now updated with the most recent information. And in this study, what they did is that they took these women who had more worrisome estrogen receptor positive breast cancers, and all the women received chemotherapy. They were all going to receive hormonal therapy, and half of them also received immunotherapy. And as you know, immunotherapy has been used in many, many cancers and has been a very successful treatment. And what they saw, if we can make this work, there we go. What they saw is that women who received the immunotherapy were more likely to have all the cancer go away in their breast and their lymph nodes, and that it was about a 10% difference. So if you received chemotherapy alone, there was roughly a 15% chance that all the cancer would disappear. If you got immunotherapy as well, it went up to 25%. Now, this is too early to start using this in clinic, but if these results demonstrate or lead to the demonstration that there are fewer recurrences in these patients, then we will have a new treatment, and that new treatment is immunotherapy here. So, but there are other advances for patients like this, and those other advances are drugs that are called CDK4/6 inhibitors. And these are drugs, there are 3 of them. One is called abemaciclib or Verzenio. One is called ribociclib, or Erica, what's ribociclib's brand name? Kisqali, thank you. I'm so used to calling the drugs by generic names that I can't remember the brand names. And finally, there's palbociclib, which is called Ibrance. And these drugs not only are useful in patients who have advanced breast cancer, but 2 of them have been shown to help prevent recurrences. The one with the best data is this drug, which is called abemaciclib. And this drug, given with hormonal therapy, seems to be quite effective in helping to prevent recurrences in women with estrogen receptor positive breast cancer. And essentially what this did was that it prevented recurrences in 1/4 of the women who would otherwise have a recurrence of cancer. Now, the downside, it's 2 years of therapy, and it's 2 years of therapy with some side effects. And so for every patient, it's really a debate, is it worth it to take this and put up with those side effects for 2 years, or am I going to take my chances? But increasingly, I think you're going to see these used. An issue that came up in our conference yesterday is that it may be harder to take these drugs if someone has already received chemotherapy. And so that's where it becomes very important to know just how beneficial the chemotherapy is and whether we really need to give the chemotherapy. All right. So I'm going to end talking about disparities and then talking about communication and relationships between patients and doctors. So this slide shows all of the many contributing factors to disparities. And I'm sorry, the formatting seems to have changed. This is a Mac PC thing, I think. But in any case, there are biologic contributors, things like race and ethnicity and age and genetics. There are environmental factors, there are socioeconomic factors, and then there are modifiable factors that can lead to disparities in outcome. These are data from the United States looking from 1970 to 2018. And I don't mean to be excessively political, but one can argue that the United States has just gone crazy over the last couple of decades. And those of us who are here feel like we're ready to move. And when we go back, we have to go back to our small academic institutions and remain tightly, in an envelope of some sort. But in any case, this is yet another example of how the United States is a crazy place. So if you're a black woman in the United States in 2023, I'll get to this slide in a second, and you're 20 years old, you have twice the chance of dying from breast cancer by the time you're 50 compared to a 20-year-old white woman. And that's just not okay. Now, you can argue that young black women get slightly different breast cancers, that they tend to be higher grade cancers, and maybe they're biologically different, but that may also be a function of environment, and it may be a function of all sorts of factors that we don't fully understand, of diet, of many, many other things. But the bottom line is that breast cancer mortality has clearly gone down. It's gone down more for white women than black women, and in 2020, there is still a substantial difference in mortality between women who are black and women who are white in the United States. And if you look at mortality in this century, and you divide women up according to their race and ethnicity, interestingly, Hispanic women are the ones who are least likely to die from breast cancer, and no one really understands this. But black women, whether they are Hispanic or non-Hispanic, are the two top lines with the highest death rates from breast cancer. And if you look at our nation's capital, a place where you would think that we might pay attention to the health of people, and if you compare black women and white women, what you see is essentially twice as high a death rate for black women versus white women in our nation's capital. Of course, the same occurs in many, many other cities. I just think it's particularly dramatic to talk about Washington. And that's just one factor. If you look at cancer mortality based on poverty, if you are poor, you have a higher chance of dying from breast cancer. If you lack a high school education, you have a higher chance of dying of breast cancer. If you don't have health insurance, if you have pre-existing mental health problems, if you are not a heterosexual woman, you have a higher chance. So basically, in my mind, anything that makes you different from the norm in the United States, and probably in many countries around the world, puts you at higher risk of having a poor outcome with breast cancer. And probably most of this is not about biology. It's probably much of it relates to access to care, and then to what extent other factors are contributing, we don't fully know. But this is something that we urgently need to address. I've been told that this is much less of a problem in Australia, but that it's not a non-issue. And there are still disparities in healthcare here, and there certainly are around the world. And this is just another one of my thought experiments, but it just imagines that we can get rid of the disparity between black and white women, and we can get rid of the disparity in terms of health insurance versus not. And if we were to just magically eliminate those disparities, just those two, we would save over 5,000 lives a year from breast cancer. So I want to end this just talking a little bit about clinician-patient relationships, and I'm specifically using the term clinician because I don't think this is just about doctors. I think it's about doctors and nurses and what we call nurse practitioners and physician's assistants. And some people in the United States call those people providers. Providers to me sounds like service professionals, and I don't like to think of myself as a service professional, so I refer to it as clinicians. So it's meant to be more inclusive than doctors, and still a term that I can live with. I want to, my thoughts here come from what I've learned as an oncologist and from just living life. And what does it tell us about how we can influence the relationships we have with patients? So, and this comes, I will tell you, from what was my address at the annual meeting of the American Society of Clinical Oncology when I had to give a presidential speech. And I think there are really 5 lessons that I just want to review briefly. So one is that when you're healthy, it doesn't matter who provides your health care. I mean, you know, the amount, if you think of quality of life as a big pie, the piece of that pie that is made up by your relationship with your doctor is a little tiny sliver, because you go see that person every 3 years when you have a sore throat that won't go away for a month or something like that. But when you're sick, and I don't care whether it's that you have breast cancer or whether you have cardiac disease or whether you have anything else, the portion of your quality of life that is about the relationship you have with your healthcare team gets bigger and bigger and bigger. And I actually, and you know, call me a cancer snob because I think I have the best medical job in the world being a cancer doctor. But I think that this is even more important for cancer doctors and cancer patients than almost any other setting. And maybe that's because cancer is such an emotionally charged disease in all of our societies. So I think that as clinicians, we have to remember that the impact we have on patients and on their families can be really, really huge. I also think that patients need to remember that if they're not in a good relationship, it's up to them to figure out how to get out of it. I mean, I'm not trying to put too much responsibility on each of you, but if you're consistently not able to communicate with the people taking care of you, that's a problem. Now, if you keep getting into new relationships and you keep not communicating with everyone you see, then maybe you have the problem. But, you know, that most of the time that's not the case. And I will say that of the thousands of patients I've taken care of, I can probably count on a couple of hands the ones who I think are really having a problem with their communication. Lesson 2, and this is less about relationships and more about sort of just how you should all think about things related to cancer. Science really makes a huge difference. I mean, that's why, you know, we're sitting here in a research institute that also provides clinical care next door, talking about all of this. Scientific discovery has been huge over the last 3 decades. What we know about breast cancer, what we know about melanoma, what we know about lung cancer, and all sorts of other things is truly miraculous. And it has come from basic research and basic research that has been translated to new therapies and new understandings. It's not just about new therapies, it's also understanding when you should apply those therapies, so we have to understand the cancers better. But science has changed the lives of people with all sorts of health problems, and we really need to support it and have a great deal of respect for it. Lesson 3, and this is sort of a lesson for doctors, but I'll share it with you, which is that I think that sometimes you might think it's easier to provide care to a patient if you yourself have been through that. I don't necessarily think that that's the case. I think that if you yourself have been a patient at times, you can draw upon that. But the truth is, we all face challenges in our lives. And as doctors, one of the things that we have to do is figure out how to tap into our own experience so that we can use that to communicate and to heal and to understand what someone is going through. And I think that that's something that as as clinicians, we just need to be more aware of, and that's the point that I was making there at our meeting. I think it's also very important for all of us, and a little bit, and I'll get to this, for all of you. And by the way, I'm sort of dividing it into us and you, and it's really not us and you, it's sort of all of us. But but as the people providing care, I think we have to remember that different people respond to things very, very differently and make very different decisions. People have different emotional responses. People make very different decisions based on really rational choices. So somebody who's a concert pianist, who cares a great deal about their fingers being able to touch the keys and feel them, may decide that they're not going to take a drug that is going to cause neuropathy ever. It's just going to totally destroy their life. There may be another patient who says, you know, my total priority is taking care of my 3 young kids, and I don't care what happens in the future, but I can't do anything at the moment that's going to interrupt that. And so people can make very different choices, and we have to respect that. And finally, and I think that this is really, really critical, I think we all have to remember it, is that stigma, having an illness is bad. Having an illness that's stigmatized is much worse. And so think of those years, and hopefully none of you have experienced this, but you heard about it in the past, when women were ashamed to come forward with a diagnosis of breast cancer. Some of you in the audience, I suspect, are old enough to remember people talking about that. That still exists in many parts of the world. In the Middle East, it's a very, very common problem. Let's step outside of breast cancer for a minute. Let's go to the world of lung cancer. Is somebody who smokes and gets lung cancer versus someone who doesn't smoke and gets lung cancer, does the person who smokes, should that person be stigmatized? Should they get less empathy from us? And I would argue no. Very strongly no. And I think we just have to remember that illnesses aren't people's fault. Everybody, you know, people are always trying to blame themselves. What did I do? You know, I've been too stressed the past 3 years. I haven't taken care of myself. That's why I have breast cancer. And, you know, in truth, blaming doesn't really help. So these are just all thoughts I've had. I think that among the most important partnerships that we can have are partnerships with people who don't have all of the resources as we talked about. So equity is a major issue, and we need to consider the challenges faced by people who confront cancer and who are from racial and ethnic minorities, people who live in poverty, people with limited social support, members of the LGBTQ+ community, people with pre-existing mental health challenges, and on and on. And I think that sometimes those partnerships for clinicians may be harder because those people are often less like us. They may be harder than many, but they're probably the most important partnerships we can forge, and we just need to remember that. And finally, I'm just going to put forth the idea that if, as a doctor, you partner really well with your patients, I actually think it's an antidote for a problem that I know you've all heard about, which is burnout across the board in our societies and burnout among healthcare providers. And I think that if, as challenging as it is sometimes, I'm not expecting a pity party here, but as challenging as it is sometimes to be a healthcare provider, I think that you can avoid that sense of burnout to a significant degree if you really feel like the kinds of relationships you have with the people you take care of are something you can be proud of. So, there are many unmet challenges. I'm just ending. I think that there are 4 categories that I've talked about: the need for new therapies, the role for appropriate treatment de-escalation or bringing down the intensity of treatment, or in some cases, not doing a treatment. The problem of cancer care disparities and cancer care equity is huge, and I think that it's we're really missing an opportunity not to embrace this idea of enhancing clinician patient partnerships. We have made a significant dent, more than a dent, in breast cancer. We've made like a big hole in breast cancer mortality in developed countries. And I actually believe that in the next 10 years that we will probably have all the tools we need, meaning drugs and other therapies, to be able to tell a woman diagnosed with breast cancer that it's not something that should take her life. I don't know that we're going to be able to say we can cure everyone. I certainly don't think we're going to be able to prevent breast cancer in everyone. And I don't think we, in fact, will be able to prevent death, because I don't think we'll deal with all the issues related to disparities. But I think that the advances have been incredible. I think that healthcare delivery and all these social factors we've talked about are going to become more and more critical, and clinician-patient partnerships, I think, continue to evolve. And in spite all the challenges in medicine today, I think we can really push for them to continue to improve. And with that, I thank you all very much. It was a pleasure to talk to you. This is where I am.
Thank you so much, Eric. Isn't he incredible? Such an amazing mind and a giant heart in one person. So thank you. And Dr. Weiner will join the panel that we'll have at the end today, and so some opportunities to kind of learn a bit more about some of the points he made. So now I'd like to introduce my colleague, Associate Professor Liz Calden, who is a leading breast cancer researcher based here at Garvan, and she's going to give us a summary of some of the breakthroughs that have happened on site in breast cancer research. Liz.
So, hello everyone. It's a real pleasure and an honour to be here today to present on behalf of my colleagues here at the Garvan Institute. I'm surrounded by an amazing team of researchers, and today I'm going to give you some highlights of some of the research that's been going on at the Garvan. Now, we've already been told a lot about breast cancer, and I know this is an audience that already knows so much, but just to summarise, this is just an extremely common disease, and it occurs in about 1 in 7 women. And what that means is out of every 100 women, about 14 women are going to get breast cancer. For those 14 women who get breast cancer, if we look back to 1930, only 3 of those women would have been alive after their diagnosis. But where research has taken us is it's actually taken us to the point where 11 of those 14 women are alive 5 years after diagnosis in 2023. So this is our incredible journey of research, but unfortunately, we still need to do more. And one of the major reasons for that is that there's a high rate of recurrence from breast cancer. And what this means is that another additional 5 women after getting diagnosed with breast cancer will go on to recur from the disease. And this is really the problem at the Garvan Institute and other research institutes around the world that we are tackling to try to improve outcomes from breast cancer. So how does cancer research help individual patients? One of the things that we try to do as researchers is really look at that whole patient journey and try to see where we can improve different parts of that patient journey to get a better outcome. So this is a schematic of the patient journey, thinking about kind of that first detection of symptoms, a proper diagnosis, moving on to a treatment choice, and then moving on to picking different therapies and eventually, hopefully, doing very well after those treatments. What we do when we superimpose research on that is we ask certain questions. We ask questions like, how did the cancer start in the first place, and can we do something about that? What type of breast cancer actually occurs, and how should we treat that specific type of breast cancer? And finally, what sort of treatments and tests can we do to detect a recurrence of breast cancer and treat it better? So at the Garvan, we've got an amazing team of researchers, and I'm really sorry, but my slides have actually come up a bit differently. I'm not quite sure who's missing here. I'm actually missing one person. I don't know who it is, but these are examples of some of the team leaders we have here at the Garvan Institute. And each of these people leads a team. So all up, as Alex said, we have about 50 to 60 breast cancer researchers here at the Garvan who do an incredible job leading different aspects of breast cancer research. So I'm just going to tell you about a few of the highlights from our research this year. And to start off with, I'd just really like to tell you about the research from Professor Sue Clark's group and her colleague, Associate Professor Claire Sterzacher, and their work on epigenetic changes in breast cancer. And I am sorry, I'm a little bit disconcerted at the moment because my slides are actually all quite different to the ones I handed in before, so I'm sorry if I'm a bit stop and start at the moment. So Sue's group works on looking at the changes that occur inside a cancer, and cancer cells are full of DNA. And what's really interesting about cancer cells is that we look at the DNA inside a cancer cell opposed to a normal cell. There's often these tiny little changes in there which are called epigenetic changes. And in Sue and Claire's group, they've been looking at those changes, and one of the things they have been doing is looking at whether those changes can be used to improve blood tests for looking at recurrence of breast cancer. They've been working on a way to look at liquid biopsies, so that's taking a blood sample from patients and then looking at the changes between normal blood and tumour blood to see if there are differences there. And what this has allowed them to do is to develop a new approach to a test in the clinic, which is they've recently gained extra support for by a purchase of a machine called a ddPCR machine, shown here, which will help them optimise this test and hopefully take this further in the future so we're able to improve testing for recurrence of breast cancer. The second area I'd like to tell you about is how different researchers are thinking about improving the way we give therapies to patients. Now, this is a schematic of a breast cancer, and what you can see here is just this kind of picture, and a breast cancer is made up of cells that grow uncontrollably. But it's not just made up of that, it's actually often got another lot of things associated with it here, and you'll see this kind of stringy substance around this particular cancer. And that's this, what we call fibrosis, or this kind of shell that can form around a primary cancer. Now, in Professor Paul Timpson's group at the Garvan, they've actually been working on how to attack that fibrotic shell with different therapies. And the reason they want to attack that fibrotic shell is if you can break it down, maybe we can get cancer drugs better into those cancers. And here's an example of how they've been doing that with a particular drug called a ROCK1 inhibitor. And what you can see here is an image of a model of cancer before treatment. You see this kind of purpley pink staining. That's the fibrosis. They treat with the inhibitor, they start breaking it down, and this will hopefully allow chemotherapy to get into those cancers. Another important approach that we have at the Garvan Institute is from Associate Professor David Crouch's group, where they're really looking at the different ways to treat metastasis of breast cancers. Because often what happens is it's not actually the primary disease that causes death from breast cancer, it's actually the recurrent disease where the cancer is spread to a different organ and then starts to grow uncontrollably. And this is particularly the process that David's group is targeting. Sharissa and Dave within the group have been developing a specific therapy called the drug K12, which they're now using to shrink those tumours that grow at other sites and hopefully better treat metastatic breast cancer. Another approach I want to talk to you about is the approach from Associate Professor Christine Schaffer's group. Now, this is again about metastasis and how do we better treat metastasising cancers. And Christine's approach is to really look inside those tumours and look at what are the differences in cells in tumours, because not every cancer cell is the same. And some of those cancer cells are actually the precursors that go on to form metastatic disease. And that's what Christine's group has been working on, identifying those precursors. So what Christine's group has found, there's a particular factor expressed on some of those aggressive cells, and they've actually developed a drug targeting approach towards those particular cells, and that's now in a clinical trial here at the Kinghorn Cancer Centre. Shabani Gupta, who Emma Renshaw mentioned earlier today, was one of our Estee Lauder Prize recipients from last year, and she's been working on a secondary approach, again, looking at the same sort of mechanism of finding out those specific characteristics of particular breast cancer cells and finding out whether we can particularly target those most aggressive breast cancer cells in each and every cancer. I'd also like to talk about our own Professor Lim's work in advanced breast cancers. So again, treating metastatic disease is one of the most important things we have to do. And in Elgene's lab, he has been developing patient-derived xenograft breast cancer models. And what this is taking samples from patients, growing those within mice, and then treating those cancers within the mice to see how they respond to drugs. And here is a lovely example of a successful use of that approach, where you can see in this graph that certain drugs make the tumour shrink, and they have performed much better than the standard of care, which is here shown in the pink line. And it's based on these amazing results that clinical trials are now being developed around the world to look at different drug combinations in the clinic. And just as one last project I'd like to highlight, and that's from Alex Swarbrick's group, and that's really looking at how we can work better with our immune systems in breast cancer. So immunotherapy works very well for different types of cancers, for example, melanoma, but it's never been particularly successful in breast cancer, and that's a problem. And Alex's group has really been doing a deep dive into why immunotherapy doesn't work well for breast cancer. Because when we find out the why, that's something we can build on and then figure out how we can use these drugs better in the future. So in Alex's group, they've recently published a great paper looking at just this question. And just to give you an example of the data that's been generated from this, they found that when they treat different models of cancer with types of immunotherapy, they find that it enriches for certain types of breast cancer cells. Some breast cancer cells seem to respond really well to the immunotherapy, but others don't. And this is really the type of foundation for future work to better optimise the use of immunotherapies. So I hope you can see from this little snapshot I've given you of quite a few projects in just 10 minutes, we really are looking at how we can better treat breast cancer across the spectrum of the patient experience, both developing better tests for breast cancer, better treatments, and better treatments in the recurrent setting as well. And to finish off, what I'd like to do is I'd just like to thank you all for your attention. Thank you all for your amazing support of our research. This does not happen without the support of our community and the support of our funding bodies that are listed here. But I'd also particularly like to thank certain people, and these are our consumer advocates, who are people who have had breast cancer in their lives and advise on our breast cancer research projects. So thank you very much, everybody.
All right, so I've got a very short presentation about some of the clinical advances in breast cancer at the Kinghorn Cancer Centre. Can you move forward the slide, please? Great. So there have been a number of new drugs that have been approved in the last year or two that makes it really increase our treatment armamentarium for patients. These are two examples of what we call antibody drug conjugates. So what this new class of drug does is combine the targeting potential of antibodies such as Herceptin that targets HER2, or another antibody which targets a protein called TROP2, and it combines that targeting strategy with a small amount of chemotherapy. So the antibody then takes that chemotherapy directly to cells that express that particular protein. So there are two drugs in this class that have actually just been made available under the PBS for patients with advanced breast cancer, and one of them is called sacituzumab govitecan, a bit of a mouthful, and the second one, also a bit of a mouthful, is called trastuzumab deruxtecan. So this is very exciting. These drugs are routinely used in the US, in Europe, but we now do have access to them in Australia. Next slide, please. Great. Another drug that's also been recently approved is immunotherapy. I think Eric alluded to immunotherapy earlier on. This is now available for use in Australia, once again funded by the PBS for metastatic breast cancer. And even though some indications are not approved yet, such as for early stage triple-negative breast cancer in a preoperative setting, we do have access to some of these drugs through compassionate access programs provided by the pharmaceutical companies. Whoops, sorry. Forward and forward. Okay, unfortunately, we have not made progress with some genomic assays. So some of you may be familiar with the assay called Oncotype. Eric also presented some data with Oncotype, which is routinely used in Europe, in the US. Unfortunately, in spite of multiple applications, it has not been funded in Australia, and patients self-funded to the tune of $5,000. This continues to be a problem because this test does help us work out which patients do need chemotherapy and which patients can avoid chemotherapy. But unfortunately, there's been no progress on this front. Now, one of the things that is increasingly used are molecular screening assays looking at specific mutations in the cancer. These tests are also expensive commercially, but thanks to David Thomas and a company called Omico, there is now a national molecular screening program which was designed initially for rare cancers, but with prolonged conversations with David, we've convinced him that we should be doing this routinely in breast cancer, particularly early on in breast cancer. So now this is actually available. It's not funded by the government, but it's funded by this research initiative called Prospect. So this is available throughout our country. So a major part of our focus at the Kinghorn Cancer Centre is to run as many clinical trials as possible. And what are clinical trials? It's a type of research that evaluates new tests and treatments on human health outcomes. And we do have a large clinical trial program here at the Kinghorn with 18 breast cancer trials currently, where patients partner with us to improve treatments and outcomes. And we have a number of different types of trials. It's not just focused on cancer therapy. We've also got prevention trials, supportive care trials aiming to improve tolerability, decrease toxicity of drugs, genomic testing studies, as well as novel imaging studies for breast cancer. And these can be found on our website. Just to highlight some new classes of therapies that are currently being evaluated in our clinical trial portfolio, we have new anti-hormonal therapies. Previously, we've just used tamoxifen and aromatase inhibitors such as letrozole, and this is a completely new class of drugs which are oral and easy to take and have a completely different side effect profile. We've got new antibody drug conjugates, such as I've mentioned, 2 have been approved, and we've got new ones coming through that we're evaluating. We have also new cancer mutation-directed therapies directed at specific mutations. And it's critical, therefore, we know what mutations exist before we can actually enroll patients onto this trial, these trials. So having that Prospect National Molecular Screening Program up and running allows us then to detect these mutations, which will then allow us to allow patients to participate in these trials. We also have what we call ctDNA-guided treatment strategies. So tumors release DNA into the bloodstream, and we have tests now that can actually detect very low levels of circulating tumor DNA in the bloodstream that we can then collect, analyze, and guide treatment strategies. We have a number of repurposing drug therapies here, trials here, whereby we use a drug that's effective in another disease, and we try to use that in breast cancer, obviously following a lot of scientific work that is done to develop that rationale. And we've also got cancer vaccine trials here as well. So we do have a big portfolio of clinical trials. One of the things that we always do at St. Vincent's and the Kinghorn is to invite patients to partner with us by giving us a bit of themselves. And we collect tissues of all sort, pre-cancer tissue, as well as cancer from the breast, breast cancer, as well as metastatic cancer. So I see a lot of my patients out in the audience, and I know a lot of you have actually given us a piece of yourself, and I do thank you for that, because this really forms the foundation stone for a lot of the research that happens here at the Garvan and beyond. So finally, and back to Eric's comment about partnership, research is not possible without our patients. Patients are critical partners to work with us to make this whole research endeavor a successful one. So I do like to thank all the patients and their families who've partnered with us in our quest to improve the outcomes of patients with breast cancer. What drives this partnership is a desire to make the world a better place for the next generation of women. And I think a lot of you participate in trials, not necessarily for your own benefit, but out of a true sense of altruism. So we thank you very much that we have the privilege to partner with you here at the Garvan and the Kinghorn. Thank you very much.
Thank you, Elgene. And before you, thank you, Liz. Really fantastic summaries. And I think you can get a sense for the pace of change that's happening here locally, but also happening around the world. So now we're going to have an informal panel with some of the speakers that we've already heard from, and an opportunity to kind of dig in a little bit into some of the topics that we discussed. So I'd like to invite to the stage, please, Dr. Weiner, Elgene, yourself, Liz, Claudia, and Professor Sarah Hosking, who's the CEO of the Cancer Council New South Wales. So as some of you may have noticed on the way in, we collected questions from you all. And so I'm going to do my best to address these in the 15 or 20 minutes or so that we have. So Sarah, I'd like to start with you. We've heard a bit about the background of everyone else on stage, but I think you've actually got a pretty fascinating backstory into how you ended up in the role you're in now. Would you mind sharing that with us?
Oh, okay. Can you hear me okay?
Yeah.
So I started out my career actually as an optometrist many years ago, and so really have deviated a little bit from those days. Went into research, spent a good 10-15 years in research, and transitioned across into the not-for-profit sector in about the early 2000s. So in cancer, I worked in paediatric palliative care for a period of time over in Melbourne for about 4 years. I then moved to the National Breast Cancer Foundation, where I was CEO for 6 years, and I've been at the Cancer Council New South Wales now for 2 years.
Great, thank you, Sarah. And the Cancer Council New South Wales are truly phenomenal supporters of research, both in New South Wales but also nationally. So on that point, we've heard about the phenomenal research that's taking place and its increasing reliance on new technologies. And so these technologies aren't cheap. So doing research costs us money. And it's a challenging landscape in which we work. And Liz, I thought I'd be interested to hear your perspectives on the research funding environment and the challenges you face, but also the opportunities we see in acquiring funding to do our research.
Yeah, thanks, Alex. I think for those of us who are pure researchers, it really is a labour of love. It's not a career. It's not a career that gives you really long-term job security or pays particularly well. And the people who are in this career are really doing it because they love understanding biology and they love getting better outcomes for patients. But one of the things we really strive for is to make our research better and better. And definitely the new technologies that are now available really enable that. Some of them are very expensive. They're so sophisticated. I can't believe the things we're doing now that we weren't doing 10 years ago. It's absolutely incredible. But unfortunately, those are very expensive technologies, and sometimes we've got more questions to ask than we can possibly afford.
And so I guess there are many sources of funding, Liz. There's kind of state and federal government funding, there are private organisations, but also there's individual giving. And so could you comment a little bit on the importance of those different kind of sources of funding for research?
Sure. So I think a very important type of funding that underpins what we do is our kind of national funding system. So that's through like the NHMRC, and that's peer-reviewed funding where we get reviews from our colleagues, and really the best and brightest projects are picked. And also in that same system is funding such as from the Cancer Council, which Sarah's of course very familiar with. And that again is really peer-reviewed funding that supports the fundamental, some of our really big projects that we run. But it takes more than just those big projects to make research happen. We have to pay people's salaries. We have to do things to make an institute run, like pay the electricity bill. And I've really got to say that some of our really crucial philanthropic funding actually makes all those things happen so that we still have a roof over our head to do our research.
Sarah, you're on the other side of the funding equation, and so I'm very interested to hear your perspective on, I guess, the state of play as it is now, but also the future. Where do you think we're going in the way we fund research and organise ourselves to acquire that funding?
Oh, it's definitely a big challenge, and if you look worldwide, you'll get about 50% of funding into research is government-based, and 50% comes from more not-for-profit philanthropic sector. But in Australia, it's a little different. It's about 70% government and about 30% philanthropic. So the hero of the piece is a question mark, because it's not clear to me whether that's because the government's doing particularly well, or because the not-for-profit sector and the philanthropists can do better. I think that's a moot point. If you go back to about 2015 and look at the level of government funding at that time, it was around about, for cancer, it was around about 200 million, just under 200 million. Last year and the year before, it's more like 150 million. So it's actually gone down over the last few years, at a time when, of course, as we've just heard, the costs are going up. So it's a really huge challenge. And if you think about cancer and you look at something like the NHMRC, about 11% of the funding is based on cancer, where the actual impact, the health impact of cancer is more like 17%. So we're really kind of not quite cutting it. So I know that the challenge is huge. So when I think about the future, I think, I love to look at the American model. I think that the US do probably better in that sort of philanthropic space. I think that perhaps culturally they're more aligned to it. There's so much more that we can do. So I suppose my hope, leading the Cancer Council, is that we can do more and better over the coming years, and that we'll see that levelling off, perhaps because we catch up, perhaps because the government continues to challenge us and continue to increase their funding as well. But I'd love to see both happen, and I think that's what's going to be needed.
I think from my perspective as well, one of the changes in the landscape I see is an increase in the funding of very large programs of work, where we kind of drive collaborative teams to take projects right from the very fundamental science through to something with kind of a clear, measurable clinical impact. And I think that's the kind of thing that the community expects, to have something that can be explained to them in terms of the kind of outcomes from those funding investments.
Yeah, and Alex, I think there's been a bit of a cultural shift in that. I think that researchers have got better and better and better at recognising each other and working together and being less fearful of the challenges of collaboration. And I think that will really help to build the nature and scale of projects that we'll see as we go forward. So I agree with you.
Right. So looking at the questions that were handed in before the session today, there's a huge interest in new treatments. And, we've heard quite a bit about that already, but perhaps not a lot about one of the more aggressive types of cancers, these triple-negative breast cancers. They are more frequently these kind of lethal cancers that Dr. Weiner spoke about. And they've been a really kind of intractable problem. So, Elgene, could you tell us a little bit more about some of the new therapies that are coming out in that space? You mentioned a little bit about these antibody drug conjugates that clearly they've got Dr. Seuss to name, sacituzumab governatican and so on. Where do you see the space for them? Is that going to be a new growth area in treatments for cancer?
Yeah, we're certainly doing better with more therapies, but it is still a very challenging subtype of breast cancer to treat. Um, I'm glad that we have been able to fund the immunotherapy for triple negative breast cancer after a short delay. And we also know that this class of drugs are also effective in women with early stage triple negative breast cancer rather than late stage metastatic. Um, we're fortunate here in Australia that whilst we don't have the same access to drugs as our American counterparts, that we do have many clinical trials. And what we can't access through the PBS, uh, one of the strategies that we use is to have clinical trials with those active therapies that we can actually put patients on, and patients will therefore get access to these drugs. Pharmaceutical companies, even though they've got a relatively bad name, have actually stepped up to the game as well. And whilst we don't actually have quite a number of drugs on our PBS, a number of companies have actually made these drugs available on compassionate access. So I think it's critical that, Eric talked about that trust and that relationship with your clinician, that your clinician be very much aware of what the clinical trial landscape is in Australia, and also be very aware of these access schemes in order to allow our patients to maximize their access to effective drugs. Do you have any comments about triple negative, Eric?
Um, I think that we've seen the development of a number of new treatments over the last several years, and I think it's just the tip of the iceberg. So, two things. One, I think our understanding of the heterogeneity in triple negative breast cancer, meaning that it's not one disease, it's actually multiple diseases, and it needs to be treated probably with a number of different approaches. So that's important. But then actually coming up with the new treatments, and I think the antibody drug conjugates, and my colleague, Dr. Mayer, there sitting in the front row, talked about that 2 nights ago. 2 nights ago, yeah, yes.
So a critical piece, obviously, in taking these new treatments through to clinical implementation are trials. And so, Claudia, from your perspective, I understand you're participating in what sounds like a really groundbreaking clinical trial now that I guess combines new drugs but also new tests all in the one trial. How did you get into that trial, and what's been your experience of participating in a clinical trial?
Through Dr. Lim, I joined the trial by talking to Dr. Lim. Okay, did you hear that? Yep. No, I got into the trial through Dr. Lim. To me, I have experienced a very positive result to my drugs. As I said earlier, to me, the side effects are very, very minimal, and I hope I can stay on this combination of drugs for quite a long time. I feel that I will. I just have that feeling. Because I'm incredibly healthy, I just do not feel that I have any sickness at all.
That's fantastic.
And I'm very, very grateful to Dr. Lim for putting me on the trial.
I'd just like to highlight that, with a lot of trials, you don't necessarily get access to necessarily the new treatments. Often in trials, there is what we call a control arm where patients get randomized to the standard of care treatment, which is the current treatment. But I think we need patients in participating regardless of what treatments they get allocated to, because we will not be able to move the field forward unless we have a comparator group. And unfortunately, we don't get to choose which patient gets which treatments. It's actually done on a computer, and patients get put equally on the two arms typically. But that being said, I think when I speak to my patients about trials, I don't talk about that necessarily getting the treatment of choice necessarily. I talk about why we should participate in trials, and as I alluded to earlier, it's really that altruism, that desire to make the world a better place for the next generation of women that should drive us to participate in trials. And if that's a driving factor, then it almost doesn't matter which treatment one gets allocated.
Is this on? People hear me?
That's not on, I think.
Now it's on.
There we go.
Okay. So most of the trials that women with breast cancer participate in are either phase 2 or phase 3 trials. And in a phase 2 trial, you typically know exactly what you're getting, and we're looking at a new treatment to define exactly how active it is. And I think when you think about phase 3 trials, which are randomized trials, the way to think about it is you're either getting the best standard of care, or you're getting something that a lot of smart, thoughtful people think could be better. Now, there's not a guarantee it's better, and there's always the possibility that it could be worse. In truth, most of the time it's not worse, some of the time it's not better. But the reason we have made such advances in breast cancer treatment is because of people who have decided to participate in trials. Because I don't know of any new therapy that goes from the research lab to the pharmacy shelf without a big clinical trials piece in between. So it really is pretty critical. And it's also critical that the clinical trials themselves be designed and conducted in a scientifically rigorous manner so you can believe the result. The last thing you want is to see the results of a trial that in the end mislead you and conclude that treatment B is better than treatment A when in fact it's no better. And so we have to take great care not to have that happen.
So Eric really made the point that the clinician-patient relationship is so important, and obviously part of that is education, so that the patient can be making an informed choice in deciding about what they want to do. Elgene, how, in your practice, how would patients or their families learn more about the new trials that are coming up, the new treatments that are available, so they can be an active participant in that decision making?
Yeah. A key part of what we want to do is to help patients make an educated decision. I try my best not to be paternalistic. I think I'm too young to be paternalistic. But I do want my patients to make an educated decision. So a lot of education goes on, but we have a team here, fortunately. We have the McGrath nurses at the Kinghorn who play a major role in looking after the patients, but educating the patients. I use printouts a lot because we have these resources available that we can actually give to the patients. Unfortunately, clinics are busy, as you all know. So, the amount of time that we can actually spend with the patient is often limited, but the amount of information that we want to get through is so much. So it is challenging, and we try our best.
So Sarah, Cancer Council New South Wales does a lot more than fund research. Could you tell us a little bit about that, the other kind of, particularly in the kind of direct to patients and their families, the kind of services that you offer?
We've got a really wide range of services, building on what Elgene said. So cancer information is one of our services where we provide cancer information booklets for healthcare practitioners to share with patients, and patients can access those directly as well. So that's a major area for us. We have a range of supportive care services, which is everything from transport to treatment. So particularly taking people who live in regional rural areas from home to their appointments where they otherwise can't get there. We know that a lot of patients actually won't go to their appointments if they don't have the opportunity, not just for transport, but also for accommodation. So we provide accommodation services for patients who just otherwise couldn't get to their appointments. So quite critical services, and perhaps not the obvious things that you might be thinking of, but some of the things we do. We also play a significant role in advocacy. So we do lean quite heavily on government. We're not afraid to have pretty healthy chats with government about what we think they should be up to. So, for example, some of you will have heard of IPTAS, which is the funding for transport and accommodation. We were able to persuade government, based on evidence that we have, that IPTAS levels needed to be increased so that it made access to treatment much more affordable for people and things like that. And we do a lot of work around prevention as well. So prevention is a really key area, of course, in all areas of cancer. And for us, it's everything from, sun protection in particular is something we work very closely on. We're also, constantly talking to people about healthy lifestyles and things like that as preventive measures. We've also done a lot of work around smoking over the many, many years. We've had some huge wins in smoking, which apparently appear to have been somewhat undone by vaping. Vaping is a major problem, and I can see some nods in the audience, but vaping is a major problem. We have worked very stringently with government, providing evidence and persuading them to illegalise vapes for anyone other than those who receive it by a prescription. So these will stop people being targeted for young people who are targeted, school children who are targeted by big tobacco from taking up vaping, and we know that people who take up vaping are far more likely to smoke through their lifetime. So we're trying to stop the next epidemic of lung cancer as well. So many, many things there. So just give you an idea of some of the things that we're involved in, quite significant, and research around screening and other areas as well.
Thanks, Sarah. Elgene, you had something.
Yeah, so one of the things that we're particularly passionate about is clinical trials for those benefits that we spoke about earlier, such as access to new medications, but more importantly, advancing the field forward at a pace that's much faster than what we currently have, so that patients will have data to support access to new therapies. One of the things I'm particularly passionate about is to enable clinical trials to enable patients throughout our country to access clinical trials. I think we are rather spoilt here at St. Vincent's, because we do have many clinical trials, and clinical trials is something that we do as part of our bread and butter. We try to get offer as many patients access to clinical trials as possible. But that being said, it's something that is unfortunately not accessible for many parts of our country. And there are many ways that we can try to improve this. Certainly telehealth is one of those strategies, and we're trying to pioneer some of these telehealth trial strategies here at the Kinghorn and St. Vincent's. But the other thing that we're trying to do is to allow patients to navigate the very complicated clinical trial options through a website, which is a clinical trial navigator website, where patients, instead of relying necessarily on their busy clinician or doctor, they would be able to find out more about the trials that are relevant to them through this website portal.
Great, thanks, Elgene. So as we head to finishing up time, I wanted to cycle back to something Eric said, which, to paraphrase you, I think was, in 10 years' time, we'll have all the tools we will need to end deaths from breast cancer. If I got that right. I mean, that's an exciting statement. Can you tell us a little more about what you mean, and what do you think is going to be the game changer that will kick us into that next stage?
So I would argue that for HER2-positive breast cancer, we're pretty darn close. And we're a couple of drugs away, and a little bit, and maybe where we need to understand the biology of a very small subset of those cancers a little bit more. I think that there are going to be better endocrine or hormonal therapies over the next 10 years. And I think that the CDK4/6 inhibitors, drugs like abemaciclib and ribociclib, I'm sorry, I can't use the brand names. And, one could argue that as everyone has become more knowledgeable about medical issues, the only thing that makes us special at all is that we can pronounce the names of the drugs. So I think those drugs are just the beginning of of a generation of drugs that are going to help us make hormonal therapy work better. And finally, I'm pretty optimistic about where we're going in terms of triple negative breast cancer. So, you know, is it going to be totally the case that we will be able to say in 10 years that there will be zero chance of mortality? No. But I think that we can be in a very, very, very different place then. And I think our single biggest challenge at that point in time is going to be figuring out how to deliver care, both in terms of the economics of it, but also in terms of all of the social aspects. And, you know, again, more true in some countries than others, but it's a big challenge. I
That's
think, you know, so much of this is what all of you have done in the laboratory, and really those laboratory findings bearing fruits in terms of the therapies that have been developed.
I think that's a wonderfully positive message to finish on. So please join me in thanking our panel for their perspectives. I want to thank you all for joining here, and our photographer has got some nice photos of our panel, but I want a photo of you. So let me take one. I'm going to take one where you're looking very serious and considering all the facts you've heard. But now I want one that hopefully expresses the kind of joy that we feel for the future. Yeah, so hands in the air if you feel like it. All right. That's wonderful. Thank you. So we will be serving tea and some biscuits upstairs. We really welcome you to stay, have a chat to us, take your time, and have a wonderful evening. Thank you so much.